Welcome to this TAP Integrative Featured Expert Chat. We have with us today, back by popular demand, Dr. John Neustadt. He's going to be talking with us on the topic of clinical testing through applied biochemistry. And that sounds like a mouthful, and I'll get to that later as to why we've topicked this particular area in that way. But I first want to say I'm delighted to have you back.
Oh, thank you.
Yep, really
it's great to be here.
Good. Looking forward to this interview. The information that you've written and we've provided on TAP is excellent as well, so I think this is going to be a nice compliment.
Good.
All right, so let's start. Just refresh our viewers with your professional background, if you would.
So I am a naturopathic doctor, graduated from Bastyr in 2005, went into private practice, and also continued to follow one of my passions, which is researching and writing and education, and wrote several books on what we're calling today applied biochemistry. Some people call it functional medicine, nutritional biochemistry. It's known by different things, as well as a textbook, and am one of the editors of Metametrics, which was subsequently purchased by Genova, but their textbook, Laboratory Evaluations for Integrative and Functional Medicine. I've also worked with the FDA and have 15 orphan drug designations for the potential treatment of rare diseases using natural products under my name. And I'm a co-founder of a dietary supplement company and continue to do speaking and education and consulting work with patients.
Great, busy man.
Oh, it's fun.
Yeah, good.
Fun stuff.
All right, well, I'm really happy to be talking about this particular topic, and I like that we've titled it Applied Biochemistry, because I think ultimately it is that. It's, you know, taking biochemistry and really looking at how we can assess that because of its influence on function. And that has obviously a role in both disease, but also in health and disease prevention. So I think it's a nice way to kind of drive into this area of integrative health support. So one of the tests that we're taught to start with for patients is the comprehensive metabolic panel, or the chemistries is sometimes shorthanded. Yep. Do you run that test anymore? And if so,
I do.
Why?
Yeah, I do run that test. I think it's a good general screen. It is standard of care, and so when communicating with other clinicians or talking with the patient, it's something that they all know. And it also gives a good general screen, ALT for gross liver dysfunction and damage. But in terms of liver health and the cells of the liver, the ALT doesn't start to elevate until there's actually been damage to the cells and they're leaking the ALT. But the actual metabolic processes that can be leading up to that damage actually are occurring long before that. And so that's just one example. There are other examples, for example, looking at red blood cell indices. The storage form of iron is ferritin, and that's not tested on a CMP, a metabolic panel. The RBC indices and the red blood cells will go down later. It takes 3 months before red blood cells turn over. That's a life of a red blood cell. But the storage form of iron, which is more the functional form, ferritin will actually go down long before that. And so the CMP is a good general screen, but when I want to look at actually what's happening and answer the question why, I want to delve in deeper into the biochemistry and actually try and look at the pathways and what's actually going on at the biochemical level.
Okay. All right, good. So you use the CMP to sort of maybe gauge the landscape, the internal landscape of somebody, but then I think your last statement was really well said, that then you, as a good clinician, will say, well, why are there these parameters that are showing up? And that's where the functional or biochemical testing comes in.
It does, because biochemistry is really, for me, where the rubber meets the road, so to speak, with physiology, human physiology. Biochemistry is, people get whole PhDs in biochemistry, right? But it's actually very simple in concept. It's how the body uses vitamins and minerals and fats and amino acids to do its job, and how things such as infections, environmental toxins, allergies can interfere with the biochemical pathways and cause disease expression.
Okay.
And there are phenomenal tests that we can now test each of those categories in combination and put these pathways together and make a very, very educated assessment of what actually is causing the symptoms that somebody's experiencing, instead of just making a guess based on clinical symptoms.
Yeah, so let's start. So you mentioned vitamins and minerals, and by the way, that's a great way to describe this whole thing, is that it's really looking at the substrates which the body uses to do everything it does,
Right.
figuring out what's missing, what's high, what's low. So is blood, like a blood test for vitamins and minerals, serum magnesium, serum calcium, any good?
So serum calcium is good because you have to think about, just like we do in pharmacology, what compartments are there in the body? There's intracellular, there's extracellular. So calcium does a lot of its job and tends to exist in extracellular space, in the serum. But magnesium does its job in the cells and tends to accumulate in the cells. And so a serum magnesium test, which we get on a CMP,
Right.
is only it will only show any problems in a real severe magnesium deficiency. The intracellular magnesium is going to go down much sooner than you would see it in a serum magnesium test. And a serum magnesium test is not functional because that's not where magnesium is doing its job.
Right.
It's the intracellular, the RBC, the erythrocyte blood test for the magnesium and other minerals such as zinc and copper and selenium that is the more appropriate and accurate test when we're talking about looking at these biochemical processes and targeting a very customized nutritional approach to help replenish somebody or to identify those deficiencies that are clinically relevant.
Right. Yeah, and to your point, I just was reading a research article that I think said that only 1% of all the body's magnesium is in the serum. So,
Yeah.
I mean, yeah, it's exactly what you said. It's just testing that is almost irrelevant, except when there's very severe issues.
Correct.
Yeah.
Correct.
So what, just run through some common ones. So calcium, okay in the serum, magnesium, RBC magnesium, what about zinc?
RBC. Everything else RBC.
Everything else, RBC.
Yep.
Okay. and
Chromium. Yep.
all of it.
All of it.
Okay. What about vitamins?
So vitamins are interesting. There are some vitamins are appropriate as in serum, and some are appropriate as testing, indirectly testing the vitamin through urinary organic acids.
Okay.
So when we test any blood test, for example, or an RBC test, or a plasma amino acids, or a serum vitamin, we're going to get an absolute reference range. Right? And how the labs create that is they take a set of the population, how many ever they test, N of 100 or more, and they say, okay, you're normal if you're within that 95% reference range. But that doesn't tell you or me or the patient, does this person have enough of the nutrient for their specific biochemical needs?
Right.
For what their body needs to function optimally. It's just saying, well, you're in the normal range.
Right.
And even those normal reference ranges can't really tell us in many instances what optimal is. Ferritin, for example.
Yeah.
The reference range for ferritin can be so broad depending on the lab
Yeah,
as
it's
to
huge.
be clinically
Right.
ridiculous.
Right.
I mean, I've seen, I think, 10 to 100 or
Yeah,
200.
yeah, it's
I mean,
really,
crazy.
really big, right.
Russell Blaylock, whose work I really like, has concluded and published that he believes 90 to 110 is the optimal reference range for ferritin. And I like that. And so you can correlate, I never just treat a number on a test, you want to correlate that with symptoms. And when I say never, if somebody has a ferritin of 10, they're probably going to be symptomatic
Sure.
as well.
Yep.
And then you want to bring that number up. So when it comes to how to test for the vitamins, some tests, such as CoQ10, vitamin E, I do like the serum test.
Vitamin D.
Vitamin D, perfect. I do love the serum test for that as well. But when it comes to the B complex vitamins, I prefer the urinary organic acids because it gives more information beyond just the vitamins. It talks about, or it provides data to put the puzzle together to say, is this person low in very specific B vitamins and in what combinations? And are there potentially other deficiencies that go along with that? So for example, If you're looking at a vitamin B6 potential deficiency, well, there are 2 urinary organic acids that are commonly used that require vitamin B6, and one is kynurenate and the other is xanthurenate. They are metabolic pathways of tryptophan. Tryptophan needs vitamin B6 to go down its pathway to serotonin, and if you don't have enough vitamin B6, then that pathway, the enzyme is not going to function optimally. It's going to back the products up, so you get a higher amount of the products and not enough, a higher amount of the reactants. It's not going to go downstream to the products, and you're going to get a secondary metabolite accumulating, and it spills out in the urine. So when those are high, it shows us that they're actually low in vitamin B6 for their specific nutritional needs.
Right, okay. So that's actually kind of an important point, which is that the urinary organic acids really need to be, it's a fairly comprehensive test typically, because they're not just looking at the B vitamins, but at the substrate or at the product in order to make sense of that.
That's correct. So pyruvate, lactate, other urinary organic acids, intermediates of the citric acid cycle, alpha-ketoglutarate, cis-aconitate, isocitrate, all of those can be on urinary organic acids panel. And when put together and looked more in its entirety, you can get information on B12 deficiency, methylmalonic acid, formiminoglutamate for folic acid. You can lipoic acid deficiency if they have an elevated fumarate or lactate, because lipoic acid is required to bring that glucose into the Krebs cycle. And then also adipate or suberate for functional carnitine deficiencies, because carnitine is required to shuttle fatty acids for fatty acid oxidation into the Krebs cycle as well.
And for those people who haven't ordered a urinary organic acid test, can you just describe first morning urine?
First morning urine.
And maybe just why is the first morning urine, which is in some ways you could argue a snapshot of what's happening in the body, why does that actually reflect what's happening? And is there good kind of science behind that?
So there is good science behind it, and the first morning urine is because you want to have a concentrated urine specimen, and so essentially you're not drinking all night, and for the day prior they want to reduce their water intake. It's all on the patient instructions that come with the kit from the lab. So that they have it, and in fact, if they wake up in the middle of the night, they want to collect that urine too and just put it in the refrigerator, and then pee first thing in the morning, and collect that, because you want a concentrated specimen to be able to get those analytes in the solution in adequate quantities for detection.
Okay, good. So let's talk a little bit about protein and amino acids. That's another key substrate for many, many, many actions in the body. And how do we best assess protein status? In the typical CMP, really the only thing we get is total protein and albumin.
Correct.
It's probably, in your view, not enough. So tell me a little bit about why not enough and what else do we do?
So total protein is exactly what it says. It's all the proteins. But there are about 40,000 protein coding genes in our body that then go on to produce over 500,000 proteins. So getting a total protein and just a number gives no indication of actually which proteins they may be low in. Now, if total protein is low, it can be obviously an indication of something very serious going on, which we want to rule out and want to investigate. But in the absence of that, it can also be an indication of potential malnutrition. And we want to look a little bit further too and say, okay, well, which amino acids are they deficient in and why? And how does that correlate to their symptoms and what they're complaining? It always goes back to the clinical picture and the patient. We're not treating numbers on a test, we're treating the patient. And with this applied biochemical or biochemistry approach, one of the things I love about it is that the analytes that are being reported, the abnormalities that are on the test results, they correlate so closely to symptoms that the patient is experiencing. And then when you give the nutrients that they're missing to replenish them, the biochemistry is primed and ready to go. It's just missing the nutrients. Those symptoms get better very quickly.
Yeah, that makes
typically.
sense. Yep. So free amino acids sounds like what you would recommend.
Plasma amino
Plasma
acids.
amino acids, yep.
That I think is the most appropriate. And it's important because the essential amino acids, such as tryptophan and phenylalanine and methionine and histidine, those are the building blocks for all of these proteins.
Yep.
They're the letters of the alphabet that kind
Right.
of get combined
And
in
there's a
many different ways.
Finite number of them.
There, depending on the metabolic situation and the demand, there are 9, essentially, about 9 essential amino acids. And then there are conditionally essential amino acids as
Right.
well. But they combine in different ways to make structural proteins, type 1 collagen for bone, hormones such as insulin and thyroid hormone, all of our enzymes.
Yep.
And so our body, those proteins that are produced and the raw materials that are used to produce them are crucial to us living vibrant, healthy lives. And when we're deficient, in fact, essential amino acids were discovered in the 1950s, and a deficiency in any one of the essential amino acids can cause insomnia, anxiety, depression, abnormalities in appetite, and the list goes on and on.
So when you run a plasma amino acids test, you're not looking for patterns so much, you're really looking for individual deficiencies, not even really excesses so much either. It sounds like you're,
So we're looking for both.
okay,
So looking for, typically, because it is a blood test, if it's low, it means they're actually low in that nutrient. But for example, let's say we're looking at phenylalanine and tyrosine are both reported. Well, phenylalanine is converted to tyrosine, and then tyrosine, that goes down its pathway to dopamine and norepinephrine and epinephrine. So the phenylalanine and the tyrosine can be reported on a plasma amino acids test, and if the phenylalanine is high but the tyrosine is low, it means that, or that ratio is off, it means that there's a problem converting the phenylalanine to tyrosine, and iron is required for that conversion. So then you go and say, okay, well, have they had a ferritin test? And you can look at their serum iron, look at their
Right.
RBC indices, but oftentimes those can be normal and their ferritin can still be low. Or if those are normal, because you can infer amino acids from a urinary organic acids, like homovanillate is a metabolite reported on a urinary organic acids test that is an indicator for dopamine. Vinylmandylate is an indicator for epinephrine and norepinephrine. And to continue down its pathway, you also require other nutrients. All the way down to the end, there's copper and vitamin C and vitamin B6 and
Right.
a few others. But
Right.
you get my point. So just testing one in isolation, to me, doesn't give a complete enough picture to really treat as comprehensively, really as appropriately as possible to get the best clinical benefit. You want to look at not just the amino acids, but say, okay, they're maybe low in tyrosine, but maybe they don't need more tyrosine. Maybe the problem is it's backed up with phenylalanine and all they need is iron. Maybe
Right.
they just need that cofactor.
right. So really almost doing the urinary organic acids test plus the plasma amino acids would give you a kind of more data to make some of those, plus some understanding of biochemistry, will
Yes.
give you what you need to start and some additional tests, ferritin, et cetera, but you really have enough data to mine to kind of come to some clinically astute.
Yes, I
decisions.
love that combination as just a basic combination. Now, I don't recommend this testing to every patient. I don't believe it's appropriate across the board. But I think that in terms of just the two basic panels, a
Yeah.
urinary organic acid panels and a plasma amino acid panels are great starting points. And then the question is, will you add a RBC minerals on there, a toxic metals, a plasma fatty acids test,
Right.
a IgG food intolerance test. They're different than things you can begin to look at to create a more appropriate clinical picture depending on what's presented in front of you.
Yep.
And for me, the more on a review of systems, the more systems that have abnormalities in them, that they're self-reporting difficulties or symptoms in, combined with the duration of time that it's been going on, the more chronic, the longer, and the more systems that are involved, the more, to me, it's an argument for a larger testing panel.
Okay. Yeah, good, very good point. One of the concerns, I'll just be frank, that I have around this biochemical or functional testing is that it seems that sometimes practitioners will order everything up front for every patient.
Yeah.
And I think that, although that gives a rich repository of information, it also becomes a sort of a temptation almost to treat the labs and not the patient.
Right.
Right. So the clinical relevance of these results, I think, is a really important point that needs to be addressed. So I think what you're saying is really important. You start with the patient, figure out, chronicity, extent of symptoms, use that to determine how extensively to test and, frankly, what tests to run.
Exactly. There is no one size fits all here, and in naturopathic medicine and integrative medicine in general, it should be customized, personalized medicine, and it's really about treating the patient first.
Yep.
Labs are there, and this is what I was taught in medical school, and it really stuck with me. I think my professors did a great job. Labs are there only to rule in or out a diagnosis.
Right.
And labs should only be run if it's going to change the approach to treatment.
Right.
And that's how I approach it.
Yeah, good. Going back to the plasma amino acids test, how significant is protein intake to those results, and what advice do you give patients around restricting or not protein intake prior to the test?
I don't give any advice about restricting protein intake because generally speaking, people are going to be following their standard diet. I don't give them any diet. I don't want them to change their diet. What I do ask them to do is get off of all dietary supplements for at least 3 days prior to the test.
Okay.
But in terms of that, there's a homeostasis that will exist within somebody's body given their overall dietary pattern over time. And typically people will just continue to follow that. And that's what we're testing and that's what we're looking at.
Okay. All right. Okay, so let's see, what else do we need to discuss? Let's actually maybe take this into kind of a real live example, and I know in your written content you give the example of depression in some of the case studies that you present. So let's take its cousin, anxiety, and maybe talk us through kind of a hypothetical situation of a patient with chronic, long-standing, generalized anxiety, disruptive to their life.
Yep.
Some alleviations, say palliation to some extent with maybe some conventional medications. They want to know what's going on, why they have anxiety. You want to know, so what tests would you consider?
So first, before I'd run any tests and jump directly to the test, I would do a thorough history of present illness.
Sure, yeah.
What makes it better, what makes it worse, what have they tried? Really make sure that it isn't something that they could be helped with either partially, because it doesn't always come down to let's just give them a bunch of dietary supplements because they have deficiencies, but it's also helping people understand how they can more proactively or in a healthier way deal with stresses in their life and help follow a healthier lifestyle through stress reduction. So looking at that. But if testing were appropriate to do, given that it's long-standing, given that it sounds like they've tried medications, this patient, hypothetical patient, has tried different medications, typically in long-standing anxiety, they would have tried other dietary supplements as well. I've had people come in literally with a duffel bag of dietary supplements, and it's just a shotgun approach. I mean, they've tried this, so it's like cooking without a recipe. So in that case, and I'd also look at other issues that are going on. Are they having any headaches, insomnia, gas and bloating, or postnasal drip? Are they having any muscle cramping, and calf cramping, for example? Things of that nature give indications that there may be other things going on. It's pretty rare especially in chronic conditions, whether it's depression or anxiety or many other things, for them just to say, all I'm experiencing is anxiety,
Right.
and everything else is great.
Right.
Usually there's other stuff going on. So in that case, what I want to look at is diet, first of all, and proper blood sugar regulation through diet. With the testing, you do want to run at a minimum. I would want to run the urinary organic acids and the plasma amino acids test, but in this case, I would probably also want to add on the erythrocyte or RBC minerals test.
Okay.
And I would also want, separate from that, to get a thyroid and vitamin D and serum vitamin D and serum ferritin test as well.
Okay. Yeah, that sounds like it would give you a lot of really good information about neurotransmitter synthesis. And obviously that has a lot to do with anxiety. IgG, would that be considered in this situation?
So only if, and that goes back to review of systems, if they said that the three things that I look at in terms of potential IgG food intolerances are gas and bloating, postnasal drip, and diarrhea or constipation.
Okay.
If they are having an IgG reaction to foods, typically one of those or more are going to be present. You don't usually see the diarrhea or constipation, but postnasal drip, very common, gas and bloating, very common. And one thing that I like to ask them in terms of trying to tease apart the potential causes of those symptoms is, do you feel okay in the morning, but as you go on through the day, are the symptoms getting worse? And you're fasting all night, patients fasting all night, so they're not, if it is an IgG food intolerance, they're not feeding that immune system dysfunction. But as they go through the day, people tend to eat the same foods during the day, throughout the day, at different meals. So it's getting worse, that's an indication of a potential IgG food intolerance. Now, like a Venn diagram, intestinal infections and IgG food intolerance symptoms, there's a huge overlap.
Yep, go hand in hand there for sure.
Go hand in hand. So I'd also want to ask them about antibiotic usage, ask them about any cramping or bloating, things of that nature. And oftentimes, if sometimes I will just run an IgG, but if it's potential that there's a infection as well, then I like a stool. There's a stool test that can be run to look at that.
Okay, good. Yeah, that's great. So, I have to ask you about mitochondrial dysfunction, and this is totally selfish on my part, but I'm, I find myself wanting to know about people's mitochondria often. So, I do urinary organic acid testing, and and sometimes that's not available for me to do for cost reasons, to be quite frank, because it's not an inexpensive test.
Correct.
So sometimes patients don't have the cash to do it. So I'm left with trying to figure out, without shotgunning it, what I can do. And so I'm wondering if you have any tips for me, and maybe before you get into those tips, maybe just first validate that the urinary organic acid test is in fact a good way to assess mitochondrial function.
It is a good way to assess it in a general way. And then we're talking about acquired mitochondrial dysfunction, not inherited.
Yes.
That's a whole different ball of wax. So what the intermediates going through, as I mentioned before, the Krebs cycle and into the electron transport chain feeding, that a lot of those can be tested, and we can put that together. What you're not getting with that test are the minerals that are required for those intermediate steps and those enzymes to function properly.
Good point.
And you're not getting any direct measurements of some of the nutrients like CoQ10, for example, that's required. Ferritin. So all of those in the electron transport chain, those complexes are heme complexes. So it requires iron and ferritin as part of that process. And so when you look at all of the nutrients that are required for optimal mitochondrial function, you start looking at the list and it goes and it gets bigger and bigger, and it's basically everything, right? But as a screen, the urinary organic acids test is sufficient, I believe, if that's if there's an indication that there could be some mitochondrial issues going on. Now, that's a huge category because mitochondrial dysfunction,
Right.
acquired mitochondrial dysfunction, has now been implicated in almost
Yeah,
everything.
Right,
So it's kind of a grab bag.
right. Okay, so and then it sounds like you've given me some other things to look for, serum CoQ10, ferritin,
Ferritin.
and then maybe consider some of the RBC minerals as well.
Yes.
Okay, great,
Yep.
good. So I know you are a big fan of vitamin D testing and treating. So what's your target for vitamin D? Still controversial. What's your optimal vitamin D range?
I don't know where all the controversy is coming from personally. I love it above 50.
Okay,
And
as high as it goes, or do you have a top?
I don't see any real reason to, I mean, if somebody gets to 80, I don't really target 80 or 100, but I mean, those are safe levels.
Yeah, so 50 to 80-ish.
Yes, I like 60, or even a little bit higher in general. If somebody's at 50, I think that's great.
Okay, good, good. And 25 hydroxy vitamin D is what you're talking about.
Yes, yes.
Okay.
Yes, yes.
All right, perfect. So final, clinical pearls. This is a big topic, so I know we're leaving out way more than we've talked about. The written material has more detail on all this, of course, but I think you've done a really nice job of kind of organizing this whole applied biochemistry into very logical framework, so I appreciate that. And also given some really nice details as well. What else should our viewers know?
That it all comes back to the patient. Don't get so wrapped up in the labs that you lose sight of you're talking about a human being in front of you. And you want to connect with that person. And I've made the mistake clinically at times to get either rushed because I'm behind and focus on the labs and reviewing the labs. And I always want to take a step back and say, you know, this is a person, and it's not just about laboratory values. It's not just about what supplements can I give them. It's how can this person, what does this person need?
Yeah.
How can they feel valued and empowered? What can I help them with in their process?
Right.
And the nutritional supplement piece of that is really an important piece, and the testing can be an important piece when indicated, but it is only just one piece. And so I just hope people don't get so focused on that paradigm that they lose sight of what clinical medicine really is about, and that's about people.
Yeah, good. Well said. Wise words.
Thank you.
Well, thank you very much. This has been a great topic, and thank you for joining us. I hope that you stay on the website and learn more from Dr. John Neustadt.